This week on the BackTable podcast.
And one thing I would recommend for at least the young IRs, when I started my practice or joined the practice I'm in now, typically it wasn't standard for us. We would go see some of our patients, but not all of our patients. So my first year rounding on patients, a lot of the physicians were like, your IR, what are you doing on rounds? When I would round in the different ICUs. And then after about 6 months, it sort of got to be where that was expected. And then, 12 months, a lot of the guys that I would see up in the ICU would then call me with problems directly just because we were constantly seeing each other rounding. And so for me, starting out in the IR practice, it made it to where I was approachable to other providers, and it made us more open for referrals, I think, moving forward to sort of grow the practice.
Ladies and gentlemen, welcome to the BackTable podcast. If you're a new listener, welcome. For all of our regular listeners, welcome back and thank you for listening. BackTable is a podcast committed to all things IR and endovascular.
Medtronic Abre venous self-expanding stent system is now FDA approved. Learn more at medtronic.com/Abre stent. Market declines, unemployment, the COVID-19 pandemic. Don't let headlines derail your long-term financial strategy. This BackTable episode is brought to you by Yafi Tadessa, Edward Jones financial advisor in Dallas, Texas. He'll work for you to help you understand the impact of short-term events and how to prepare for the long term. Learn how he can help you reach your financial goals. Visit edwardjones.com/Yafi Tadessa, or a little bit easier to remember is backtable.com/401k for more information. Edward Jones, member SIPC. Mike, do you have a financial advisor?
Nope.
Why not?
I don't know, man. I've been trying my best to do it on my own. But no, it's an important question. I started my current job and they didn't have a 401k that started for my first year. It was like, so I wanted to meet my contributions for that year and I didn't know how. So I didn't.
Yeah. How long do you think you're going to do it on your own for?
I don't know. I just had my third kid, Aaron, and
well, there you go.
All this free time that I thought I had, which is already very slim, is gone. So, no.
Do you have 529s?
Huh?
Do you have 529s for your kids?
No, but I have a plan to eventually do one.
Okay.
Chris Beck sent me a link to one in my current state. No. I am reaching the point where I want to make sure that I'm checking all my boxes and that I'm not getting behind on any of this stuff.
Yeah. Well, if you want to, I would tune in to this webinar that Yafi is going to do on retirement plans and tax savings. And the easiest way to sign up for it is to go to backtable.com/401k. The information will be on the website or on that page. So go ahead and sign up. I invite any and all BackTable listeners to sign up. I think it'll be definitely useful.
Okay, I'll do it.
All right.
I'm Chris Beck. I'll be your host today. I'm a private practice interventional radiologist based out of New Orleans, Louisiana. Today, we have another private practice interventional radiologist who's joining us, Dr. Ryan Trojan. Ryan, welcome to the podcast.
Thank you for having me.
Yeah, man. So originally, you kind of came under our radar when we saw your YouTube video about E&M coding. So the topic today is E&M coding. Ryan, before we launch into the topic, will you tell everyone kind of your what your practice looks like and how, why even you made the E&M video to begin with?
So I practice at a hospital called Integris Baptist in Oklahoma City, was in a private practice group, and we separated from the private practice group. The IR section did. And one of the things when we separated was we wanted to focus on E&M, whether that be inpatient or outpatient, as added sources of work RVU revenue and just to provide better clinical care. So my current practice, I've been employed by the hospital as a 100% IR group for about 2 years now. We have 5 IRs, 2 neuro IRs, and 5 IRPAs.
Holy shit,
that's
a pretty big practice. What's the hospital system like? How big?
So it's a pretty big hospital system. It's interesting. It's a nonprofit private hospital, but we're the transplant center for the state of Oklahoma. So we do all ECMO, and with that comes, a host of bleeds, all the oncological work. Mm-hmm. So the main hospital, it's a license for 600 plus beds, but they usually operate around 500 to 515. And then we have 5 other hospitals that feed in that don't have reliable IR practices. So that's probably an additional 500 beds. And some of the stuff, so we do a lot of transplant work. We're a comprehensive stroke center in the IR department. We do the majority of the stroke interventions, and so keeps us pretty busy.
How many years out from fellowship are you?
I am 3 years out.
3 years out? Okay. All right. So private practice IR, employee base, like work for the hospital. And
Correct.
when you made the jump from, your old practice to this practice, do you look back? Like what's it like? Good, bad, ugly?
Oh, it's great. So
Okay.
I tell you, my first year out, being in a diagnostic group, I think it's somewhat like a dysfunctional marriage in that, we were just together kind of because we had kids, couldn't really
Okay.
separate. But yeah, it was, a lot of infighting. And as a marriage, we were headed in different directions. So
Mhm.
I would say it's one of the best decisions that I think we've made as a practice. And for my own personal life, I can tell you, I am significantly happier working for the hospital because all I do is IR. I don't have to worry about, looking at a stack, reading a diagnostic study. So for anybody that's thinking about it, I would say just cut the cord and do it. But it can be sticky. In the state of Oklahoma, the non-compete laws are non-existent. So it's a lot easier to separate from a
Gotcha.
group. I know other places it's a little bit more difficult.
Sure. All right. So getting into E&M coding, what does E&M stand for?
Evaluation and management.
I mean, it's kind of a softball question, but why should anyone care? Like, I mean, couldn't you just go through, just do a ton of 100% IR and then just skip all the E&M coding? Like, what are the actual pros like for some of the naysayers out there?
So I think the first pro is, IR is moving more clinical. And so as we move more clinical, this is a huge piece. I think for practices that perform E&M, it's just better clinical care for the patients and it's a better patient experience. So if you come see me, I'm going to see you in consult, depending on the procedure. And then I'm going to see you for the procedure. And then any day you're in the hospital, I'm going to come in and see you and drop a note. And so number one, I think it's better patient care. Number two, it's documentation. I think, especially if you're on call on the weekends and there's a really sick patient and you decide not to intervene, then those are patients I will go see, put a consult note in so it's in the record as to why I didn't intervene. So many times, interventional radiologists don't go see the patients, and then stuff gets put in the chart that may not be accurate. The third thing, obvious, would be increased work RVU revenue. So when you look at a vascular surgeon, for example, they get about 20% of their work RVU revenue from E&M coding. I feel like as interventional radiologists, we can do the same. I think you can have a 10 to 20% boost in your work RVU revenue if you perform E&M coding.
So that was like on your, so for those of you listening, also know that we will link to Ryan's YouTube lecture. That's like the first thing how he came onto our radar. And so if you guys are interested, please listen to it. It'll be in the show notes. But I noticed in the lecture, you said that vascular surgery, it's like 20% E&M. Now you haven't hit the 20% mark. Is that like the goal? Is that like a reasonable goal for interventional radiologists? Or like, where do you think people should stand in terms of like how much of their E&M billing should be, or I'm sorry, how much of their billing and coding should be E&M versus SNI or, procedure codes?
I think 10 to 20% is a reasonable goal. So I hit my first year out 13%, but 90+% of that was inpatient.
Mm-hmm.
Still working on getting a big outpatient clinic set up. COVID kind of derailed our plans for clinic space. And since we work for the hospital, if the hospital says no as far as funding, we kind of have to wait. But I do think 10% is reasonable for most private practice radiologists if you just do inpatient E&M work, not even doing an outpatient clinic.
All right. That's fair. That's fair. One of the things that I think like to bring some awareness and really hit home for people like, on the fence, whether E&M is like worth it or not. Can you talk about some relative work RVUs in terms from like, I don't know, you can pick whatever E&M code you want, but like some E&M codes versus some procedure codes and like compare the two, like, a TIPS is, 10 work RVUs, which I'm making up that number and a level 4 visit is worth how many? Like, do you have any like comparisons off the top?
Yeah. So a simple one and we'll talk about this as far as inpatient work goes, you have what I call it inpatient hospital day 1, which is 99222. It's a level 2. And then you've got subsequent hospital days, which is 99232.
So those are just like progress notes. Like,
yeah, the follow-up ones are progress notes. And the hospital day 1 is 2.61 work RVUs. That's the exact same as a biliary drain change. And compared to other procedures like a F tube is 6, a biliary drain placement is 7.6. So for people who say, I don't think E&M is worth it, if you look at some of the data, let's say an average IR only physician does 8,500 work RVUs a year.
Mm-hmm.
They take 12 weeks of vacation, and that ends up being 42.5 work RVUs per day, if you work 5-day weeks.
Sure.
So if you can do 10 to 15 work RVUs, just E&M, then the rest of it's just procedural stuff. And so I think everybody says work RVUs aren't worth it, but it's one of those things, if you just do it every day, then it's worth it. And once you start doing the inpatient work RVUs, I've always rounded on my patients since I've been in practice, which isn't that long, 3 years, but I can't imagine not rounding on my inpatients. I can't see a day where I would do that. So.
Right. That's just not your practice. I guess one of the things that I try and stress to interventional radiologists is that a lot of times they're like in people's practice, you're already doing the work. Like most of us will see patients, inpatient consults, go up to the floor, see patients. And a lot of us round on our patients after procedures. The only thing the only difference maker here is sometimes just the documentation and then capturing that billing code. And so has that resonated with some of your other IR partners in terms of like they're doing the work, you just have to emphasize to them, man, all you got to do is just drop the note, drop the code? That's
correct. And in order to do that, I think you first have to demystify a lot of sort of misinformation that's out there. And for IR, there are no 90-day globals. There's 10-day globals for 5 things: kyphoplasty, any ablation, gastric access, venous access, and cholecystostomy tubes. Every other procedure you can bill post-operative day 1 for a progress note. And so once
let me stop you only because I think that some people might gloss over this. So like what we're talking about is global billing periods. And will you just like kind of like take one step back and tell people like what is a global billing period, and then follow up and just tell everyone why you really don't need to sweat it that much, except for a couple circumstances.
Yeah. So global billing period is the number of days after a procedure where you cannot bill for inpatient progress notes. So let's say I do a cryoablation on a kidney. I'll see that patient the next day in the hospital. I can't bill for that because it's within the 10-day global. It's all bundled. The reason interventional radiology doesn't have any global periods is they dropped the payment for most of our procedures a couple of years ago. And then in order to do that, they got rid of the globals. So I think you'll see in the future, they will go after most of the surgical codes. And then to appease the surgical societies, they'll drop the globals. So my twin brother's a urologist. If you take a 90-day global surgery for him and you make it a 0-day global, but you drop the overall RVU payment,
right?
He'll make up for it on the back end by billing for those progress notes.
Okay.
So again, like despite those 5 procedures, which we, kyphoplasty, gastric access, venous access, cholecystostomy tube placement, and ablations, you can bill for follow-up. Now, in my practice, no matter what the procedure is, even if it's kyphoplasty, it's in the 10-day global. I'll still round on those patients and the notes look the exact same. It's just that's when I'm not going to get paid for. And back to your original question, as far as implementation for my older partners, I think that templates are very, very helpful.
Sure. Okay. So I think we've tackled the global billing period, and like you said, like demystified it in a way. And if I hear you correctly, one, we don't really have to worry about the 90-day global unless maybe you're doing like carotid endarterectomies, right?
Correct. Carotid stents or endarterectomy, which most IRs aren't doing.
Sure. And then for the 10-day global, which is a 10-day period in which you cannot bill after the procedure. So like if you did gastrostomy, I think you said kyphoplasty, cholecystostomy tubes, and then any kind of liver ablations or any kind of ablation period, then that falls under a 10-day global bill or 10-day billing, 10-day global billing, where for the next 10 days you can't bill. But everything else, so like even though it's weird, cholecystostomy is on there, but biliary drain's okay, right?
Correct, because they dropped the payment for biliary drains,
Yes.
not
So that's like
cholecystostomy.
right. So that's kind of the historical perspective, is like they dropped our SNI code and then they freed us up on the back end. So now, as a profession, that's what we have to take advantage of, right?
Correct.
Okay. Will you talk a little bit about your templates? Like, I guess, tell the audience like what electronic medical record that you're using, and then how you use templates to your advantage and to kind of make this process easier and less painful.
So I use Epic, and it's pretty simple. We'll try to provide copies of the templates, but the easiest thing I've found, there's a way to go to Auto Text Editor and you can look at other people's templates. I stole all my templates from urologists. Nice. And just changed a few things to it, and then it was good to go. And it auto imports everything. It brings in vitals, labs, I's and O's. I have a separate section that covers drain output and any imaging reports. So every day I have very minimal to input into the note. And once in Epic, once you make a good note, it takes literally 30 seconds just to copy and paste it forward, change one or two sentences, and you're good to go.
Absolutely. Whenever you put in the note, and one thing that maybe the audience missed is that we're going to try and get Ryan's templates. If you would, you'll share some of those templates with us. And so for Epic users out there, we'll have access to Ryan's templates, and maybe you can borrow them, modify them, make them a little bit better or whatever. But we'll try and include those in the show notes. And if not in the show notes, we'll link to them wherever we can get them on the website. But after you put in your note, and this may be specific to different electronic medical records, then what? Like, do you just have someone who combs through all your notes, or do you actually drop the charge that like prompts a biller? Like, how does the next step work?
So for both SNI coding and for E&M coding, we do our own billing. So in Epic, when it pops up, I have a box of different codes to choose from. And so then I just pick the code. Okay. And then that drops to a queue for a biller to approve it.
Okay. And is it for some of your other partners who aren't as familiar with the codes, or is everyone so familiar that they know which ones to code for? Or is there ever like a time where, like, does anyone give you some assistance in this?
Initially, when we transferred over to the hospital, we had access to our hospital-based E&M billers. But now, after 2 months, nobody has really any questions as to what to bill, because it's pretty straightforward on the 3 or 4 codes that we use.
Okay, nice. One of the other things I wanted to demystify before we started talking about like the components of billing was a Modifier 25 or -25. Will you, one, elaborate for the uninitiated exactly what that is, and then also what you do about it?
So Modifier 25 is a modifier you append to a service if you want to get paid for E&M the same day that you do the procedure. So the same day you do the minor surgery. And it's pretty simple. The actual terminology is it's used to facilitate billing of E&M services on the day of the procedure and must be significant and separately identifiable. So when I'm doing let's say I have a septic nephrostomy tube, I go see that patient in the ICU. I'll dictate in my note the significance of why the patient was seen on the floor was to evaluate, could they tolerate moderate sedation? Do we need anesthesia? And I'll go through a list of the things I'm looking at. And then when they come down to the department, I'll put my normal pre-procedure note. So by documenting the significance of why I've gone up there, I hit that one. And then by having a separate pre-procedure note, then there's 2 different notes. So it's obviously separate from what I would normally do for a nephrostomy tube placement.
Okay. And the reason we're talking about this Modifier 25 is this: if you were just to put in a regular note, like say you decided not to see the patient in the ICU, but you were going to just see them right in the department before they rolled into the cath lab, that's kind of a red flag or not a red flag, but that's just a situation in which you can't bill for a separate history and physical apart from your procedure, right?
Correct. And you hit on a good point in that the first sentence of the note will say the patient was seen and evaluated in the ICU. Okay. So they know it's separate from the IR department.
Okay. I know there's one situation that's a little bit peculiar with the Modifier 25 that you just can't see the patients in your department. You have to be on the floor, and that has to be clear in the note. Are there any other sticky little points like that that may prohibit or restrict you from capturing like a HMP code or a E&M code before the procedure on a same-day procedure?
So I try to use this code on critically ill patients, strokes, septic patients. I think it will get sticky if you try to do it on everybody, obviously, because there's no indication. But I think if you see the patients separate from your department, it'll go through. I talked to my billers last week. One of the things that I constantly hear from the older generation is you don't get paid for E&M work, which is absolutely not true. So my payment rate's about 99% for E&M
Wow.
work. And the Modifier 25 stuff, the way I document it, the billers say it all goes through. So, I think, again, another piece of disinformation when it comes to E&M work.
Yeah, no, that's important. Can you give some procedures that maybe some good examples of procedures where you do go see the patient ahead of time, like on a same day procedure, like you said, like a septic nephrostomy tube? If I had to extrapolate, probably a cholecystostomy tube, but maybe something that would be like out of bounds would be like a paracentesis or central venous access, something like that. Correct.
So the way I look at it is if someone called me at 1 a.m. to do this on call,
Mm-hmm.
then that kind of fits the bill, right? Strokes, people are bleeding to death,
Yeah.
stuff of that nature. But yeah, we don't typically do any routine stuff, like ports or lines. We're currently not seeing those patients.
Okay, gotcha. So the billing components, and from watching your video, I know that the medical decision making is the most important part. And so will you talk about the different components that go into medical decision making, and then how that plays into driving everything else about the E&M code?
So the 3 components of calculating complexity of medical decision making are problem points, data points, and risk. And there are 4 levels: straightforward, low complexity, moderate complexity, and high complexity. So from an IR perspective, when we're figuring out and calculating complexity medical decision making, it's either going to be high complexity or moderate complexity. It's unusual to get a straightforward complex medical or complexity medical decision making or low complexity. You have to remember these charts and tools were designed for family medicine clinics. And as an interventional radiologist, we just deal with a much sicker patient population. So most of the stuff that I do is moderate complexity.
Okay. So basically once you get through all the components of the medical decision making, the 4 levels that you can end up at are straightforward, low, moderate, and high. And basically, to make everything simple for everyone, you can throw away straightforward and low. That's just not the arena in which we work. Everything's going to be moderate or high. So we're just trying to figure out where we end up in moderate and high. All right. So now I think you said the 3 components that lead us to whether or not we're going to be at moderate or high are, and correct me if I'm wrong, the number of treatment options, that's number 1, the amount of the data, that's 2, and the risk category, right?
So the first one will be like problem points.
Okay.
Instead of treatment options.
Okay. I'm sorry. Yeah. Go ahead.
Yeah. And management options is one of the categories in risk.
Gotcha.
And you only need 2 of the 3. So you would only need, for example, on moderate, if you had problem points and data points, but the risk wasn't there, you would still qualify for moderate complexity because it's 2 out of 3.
Okay.
And when we look at the
ahead.
moderate complexity for medical decision making, so for problem points, it's very simple for interventional radiology to hit 3 problem points. So any past medical history counts. So if you have a patient with acute pyelonephritis and they have diabetes, hypertension, and those are 2 problem points: hypertension, diabetes, and then obviously you've got an established problem which is worsening, which is acute pyelonephritis. That's at least 2, if not 3, because it's a new problem. So it's very easy to get to the 3 problem points because all of our patients have multiple past medical history problems. And to plug into the templated notes on Epic, all this stuff feeds in on your template. for past medical. So they're easy points to get.
Yeah. I will say that like having been like as an Epic user, I mean, whenever all that stuff auto populates, I mean, the idea to hit the number 3 is so easy because like, I mean, like people's lists now are like 12. I mean, like if you've been in the hospital for any amount of time, there's like 15 things there. So it's like you hit it right off the bat. All right. And so that's the number of diagnoses. And then the next category is what?
It's data
reviewed. Yeah. Okay. Now let's do that one.
The data reviewed, it got overhauled in the 2021 changes, which we'll go over in the future. But it's, again, you only need 3 points. So if you review labs, that's a point. If you review or order a radiology exam, that's a point. If you talk to another physician, that's a point. And one thing that is clutch for interventional radiology is if you do independent review of imaging, that's 2 points. So if I have a patient that I do a TIPS on, for example, I see them the next day and they got a chest x-ray, I'll just say, I independently reviewed the chest x-ray. There's no findings of pulmonary hypertension, small right pleural effusion. That's an automatic 2 points on the data. And since my Epic note auto-populated labs, I get points for the labs. So I've already automatically hit my moderate complexity.
Yeah. And I think like as interventional radiologists, it's pretty imaging rich. And so like you said, 2 points for the imaging review, 1 point for the data review, and then you've already got 3 points. So now you're at moderate, that moderate category in terms of the amount or complexity of data reviewed. Okay. All right. So just to back up, so we've done the number of diagnoses, and then we just did the amount or complexity of the data reviewed. And then the next category is what?
Risk.
Okay. Let's talk about risk.
Risk is complicated in the fact that within the risk category are 3 different categories. So within the risk category, you have presenting problem, diagnoses, diagnostic procedures ordered, and management options.
Mm-hmm.
And so from an IR perspective, I look at it as either presenting problems or management options. And in the risk section, you just need one of these categories to hit. So I don't need two out of the 3. I just need 1 out of the 3. So for moderate complexity, if you have more than 2 stable chronic illnesses, that's moderate complexity.
Okay.
If you have an acute complicated injury, which is most of our patients, that's moderate complexity. Also, if they're a minor surgery with risk factors, then that's moderate complexity. So anything with a 10-day global is a minor surgery. Anything with a 90-day global is considered a major surgery. So just a little nomenclature there.
Oh, so that's a good question. So if you have something like say nephrostomy tube that's not in that 10-day global period, is that not considered a minor surgery? Like that doesn't fit that bill?
So a nephrostomy tube would not be considered a minor surgery because it's
okay.
It would be considered a minor surgery. Minor surgeries are, correct myself, it's 0 and 10-day globals.
Oh, okay. All right. So almost everyone. So if we're looking at the risk category, there's within there's 3 subsets. Like you said, the presenting problems, the diagnostic procedures ordered, and management options, right?
You're right. And the management option, that comes into play for the consult or the same day note. And then everything after that is just going to kick back to problems because those will ride that patient throughout the hospital stay.
Gotcha. And then this is just something I see a lot of people doing with their Epic notes, like in terms of documentation. Do you say like at some point you have to document that like you have either chronic problems or stable problems or acute illnesses, whatever. I see a lot of people saying patient is high risk, high complexity, or moderate risk, moderate complexity for these reasons. Is that like a little blurb that you have in your note to like state like high complexity or not?
I typically won't state that if I'm seeing a patient in the ICU and I'm going to bill critical care time, I'll talk about why they're critically ill.
Mm-hmm.
But if it's a floor patient, I'll just list out on my assessment and plan, I'll just put all the problems.
Okay.
So, let's say the nephrostomy tube, it may be, acute pyelonephritis or obstructive uropathy,
Mm-hmm.
nephrostomy tube in place. Then I'll have a category for sepsis. I'll have another line for nephrostomy tube management, and then antibiotic management, I'll just say per primary. So those are 5 different problem points to kind of say the same thing.
Gotcha. Okay. And then so once you've gotten done with risk, the amount of data reviewed and the number of diagnoses, that takes you down to like your final result for the complexity of medical decision making. And that can fall into 4 categories, like we said. Will you say those 4 categories for us? Because I'm not sure I remember them.
Straightforward, low complexity, moderate complexity, and high complexity.
Right.
And really, it's the difference between moderate complexity and high complexity.
Okay.
In my opinion.
Yes. I think that's where most of us live. And so in terms of like, why is like the medical decision making component so important? Because there's other components of billing, but why is this the component? Like, why would you make your case that this is the most important component? Because this is what drives the other 2.
Because this is the only thing that you can't change. So if it's a moderate complexity clinical encounter, then you can select your code. And then based on whatever code you select, like a hospital day 1 code, then you would just document your HPI and physical to mirror the requirements for that code.
Okay. And that's one of like the concepts that I wanted to come through for like the audience, and that like once you have your medical decision making, whether you're doing moderate or high, like in terms of the medical decision making, then you just from there you just build your note to meet those criteria, right?
Correct.
Okay.
And, I'm pretty good with the computer. I think most people in our generation are. So I typically just do comprehensive HPI and exam on everybody.
Mm-hmm.
And then that way it kicks it back to the billers to figure out if it's a moderate complexity case or high complexity case. And I was surprised at how many of my encounters got kicked up to a higher level code from the billers on the back end. I would say about 30 to 35% of my stuff gets up billed based on my documentation.
Okay. So you just make sure everything's documented, and then the billers and coders will upgrade it on the back end. That's pretty neat.
Yes.
Okay. And not that I want you to spend too much time, because I think people will be able to like borrow your notes, but like, what do you do in terms of documenting for history and physical exam that are just kind of easy things to do, but also make sure that like you have a very complete, well-rounded, and as you said, comprehensive note?
So everything is templated in an Epic. Everybody knows that a lot of that stuff will auto-populate. And then to keep things simple on the HPI, for example, if I have to have a comprehensive HPI, that means I need greater than 4 description terms. So those are location, quality, severity, duration, timing, context, modifying factors, and associated signs and symptoms. So I just use very normal language and use their terms. So if I have a patient who has cholecystitis, for example, I'll say location of pain, right upper quadrant, severity is 9 out of 10, duration is 3 days, timing started 2 days ago, and so that way the billers, who most just graduated high school, not to dog them, but can go back in your note and find what they need to know. So that's the most simple way I've found to do these.
Okay. So you basically try and give a roadmap and like some very straightforward language that they're familiar with to help them mine your procedure, or your HMP notes.
Yes. And so like if you look at history, the 3 components of history are HPI, which the highest level is comprehensive, and you only need 4 elements of the HPI, which is very easy to do. Sure. Review of systems, a complete review of systems is 10 things. And then past medical, family, social history, you have to hit 2 to 9 components in each of those areas. But almost all Epic templates will auto-populate all of this stuff. If they've ever been to the ER or seen anybody, by the time an IR sees them, somebody else has put this stuff in the system.
I would concur with that. Let me ask you this about the review of systems, and this is a little bit in the weeds. Like, do you do a review of systems for your patients? Like, what does the review of systems look like?
It depends on the patient. If I'm seeing an outpatient consult for like a cryoablation,
sure,
I'll do a very extensive review of systems. If I'm seeing somebody in the hospital, it's a very truncated review of systems. And I may even say on my review of systems limited due to patient's status and current medical condition. Or I'll just say, review of systems, otherwise we're not pertinent to this problem.
Okay. And for some people who are maybe asking this question, What about like HMP components, or sorry, history components, where your patient, where you're actually doing a lot of decision making and you're reviewing a lot of things, but your patient is not contributing to any of the history? Like, you know, they're intubated. Like, how do you pull anything? Go ahead.
So I'll provide a phrase that we've approved, but basically it's just, we use it for stroke patients and intubated patients that says HPI not obtainable from patient due to X, Y, and Z, but I can provide that. It's one of my templated statements that I use in those situations.
Okay. So it's still okay to have a lot of this stuff in there, even though you may gather it from, you know, other points of the chart, family members or something like that, right?
Correct.
And then the physical exam, I assume that like you're doing like pretty extensive physical exams, and probably in the parlance of you know, the E&M coding, comprehensive physical exams. So what does that look like on Epic or whatever? You're using Epic. What does that look like?
So it auto-populates 8 organ systems, which is a comprehensive exam.
Gotcha.
And then I just go through those. And a couple free points that you get, if you have 3 vital signs in your note, that's considered a constitutional organ system. So then you only have 7 things to grab.
Mm-hmm.
So I'll grab eyes, skin, lungs, abdomen, chest, extremities, and then typically I'll say if they have, I'll find something else to go over. I don't typically, things I leave out, I don't do MSK, I don't do GU, I don't do heme lymph, and I'll do a neuro exam. And I keep it pretty simple. Neuro, grossly normal. Respiratory, no respiratory distress.
Right. Okay.
So there are shortcuts.
Yeah. I think like some people unfamiliar with this arena are thinking that maybe I have to start carrying around the stethoscope. That's like a little bit daunting for them to like be trying to pick up heart murmurs. But there's a lot you get when you walk into the room and assess the patient that you can document. Especially, I think Epic makes this especially easy, and you kind of laid it out. Like, you know, one of your assessments might be like the eye exam, and you know, maybe it's like extra. I mean, I don't know what you say, but
Normal.
yeah.
Mouth moist.
Right. Okay. Neck supple.
Yeah, neck, I just say no JVD.
Okay.
So, and then also, this is a very important part. I had to really drive this home with some of my senior partners. If you look at an inpatient progress note, which is a very normal code for us to do, all you have to do is to do an expanded problem focus history. That's 2 body areas. So if you have 3 vital signs in your note, that's 1. And then typically what I do on that, I'll have skin, drain side is clean, dry, and intact. And that's it. Boom, physical exam done.
Okay.
So it's very quick. When I do my rounds, I will talk with the patients and go over sort of expected outcomes and a bunch of different things. But I'm not doing 5-minute physical exams. It's literally 10-second exams.
Yeah, like the exams happen basically when you walk in the room, and then you spend all the meaningful time with the patient doing a lot of counseling, which maybe isn't reimbursed well. So, I mean, I think that most people who do this kind of get it. Like it's kind of playing the game in a way to make it optimized for your scenario. But I think that's a lot of what IR does. Like, you know, we have meaningful encounters in patients. We don't want to spend our time like doing, you know, some random MSK or neuro exam when it's just not pertinent to us. Now I want to kind of talk about some of the inpatient codes that, we're getting a little bit into a numbers game. And so if people aren't following us, we can, you know, just reference the YouTube video, but like, what are like the most common codes that you use? Because you mentioned that you're doing a lot of inpatient billing. What are the most common codes that like fall into like your billing and coding situation?
It's the same codes over and over again. So
yeah,
admission H&P or hospital day 1 codes, there are 3 levels. I typically bill level 2. So if I see a patient, that's 99222.
okay,
And somebody asks me to do something that's very straightforward, then I'll bill a 99222. And then every patient that I see is a 99232 for follow-up. So inpatient progress notes are 99232. That's probably at least 70% of my total billing. And
okay,
kind of a routine clinical scenario would be an abscess drain. So
sure.
Put an abscess drain in a patient, then I'm going to follow them, you know, follow drain outputs while they're in the hospital. I'm going to talk to the patient, let them know what I expect for follow-up. I'm going to see you for an abscessogram in 1 to 2 weeks. I actually teach them how to flush their own drain. If they're of low income, which is not uncommon, I will provide them drain care supplies. So all of my patients who have a procedure by me go home with a sack of flushes. I can tell you, working with partners who sometimes maybe don't round on their patients, it's very common for a patient to call and say, oh, my tube's not draining, and then come to find out they haven't been flushing it for the past 2 weeks.
Sure. So going back to the admission H&P code, which you said is like a very common code for you to drop, which, for those listening, it was 99222. Is that a code that has to only happen on day one of their admission? Or it's like, they've been in house for a while, they're an ICU patient, they're all of a sudden they need a cholecystostomy tube. Can you use that code for their like midpoint of their hospital stay?
Yes, 100%. Okay. So that's the first time that I see them in the hospital.
Gotcha.
And 10 different providers that are of different specialties could build that same code on that patient. One of those providers will be earmarked as the admitting or attending provider, but it doesn't change reimbursement or any of that or documentation.
Gotcha. Let me ask you this scenario, and it's a little bit nuanced, but say you see a patient for a cholecystostomy tube, you do the cholecystostomy tube, now you're kind of following up, and then they become septic because of an obstructing stone or whatever, and then you get consulted for a nephrostomy tube. Or does that patient still fall into your progress note kind of thing, or do they fall back into like another admission H&P? I mean, I kind of know the answer to this, but I just wanted to hear what your opinion or how you treat that.
That would still be in your progress note.
Yeah. Okay.
Because they're established patients.
Exactly. So now they're an established patient and they're just kind of falling under your progress. Okay. So I think like covering the inpatient is the easiest thing to do, but there are some scenarios that I think warrant some specific attention. And I think we've tackled like if you're just trying to get into E&M coding, like the two codes that you mentioned are the most important ones, like your progress note and then your admission one, right?
Yes. And again, just to clarify, on the admission H&P, that's just hospital day one. So you don't have to be the admitting provider to build that code. And again, I think that's a big place of confusion for most IRs as far as, they'll say, well, I can't build that because I'm not the admitting provider. But that's just a hospital day one code.
Well, but even if it's not hospital day one, can you build that code?
Yes, it's your hospital day one. So patient can be on hospital day 32, but it's hospital day one, and then everything else is subsequent day.
Okay, gotcha. So it's just the first day you're coming onto the scene.
And then another thing that we're probably about to get into is the inpatient consult codes. So 99251 through 99255.
Yes.
And the most common codes that an IR will look at in that category is 99253, which is a level 3, or 99254, which is a level 4. So typically on those, there are unique situations where I will bill those. If I get consulted and I go up and I see a patient and we talk for 50 or 60 minutes and we talk about doing the procedure or not doing the procedure, then I will bill that as a consult. And I will document in my note, we consulted, here are all the treatment options. Patient elects to go with an IR procedure. Now, if they call me for a cholecystostomy tube and a non-operative candidate that's septic, in my opinion, that's not really a consult because there's no other options besides death. So I always tell people that's the fourth option.
Sure.
So then I would just bill that as a 99222. So work RVUs for a 99222, which is a level 2 hospital day one code,
right? Or
2.61.
All right.
For a level 3 consult, it's 2.27. For a level 4 consult, it's 3.29. So oftentimes I'm billing 99222 just because it's easier. Trying to figure out if something's a consult or not can be complex, but in my thoughts on the whole deal is if you try to talk the patient out of doing the procedure, then that's kind of a consult. Okay. Otherwise, if it's obvious that you're going to do the procedure, there's not really a consult.
I see. So that's kind of your gut check is whether or not like the procedure is actually in the air or not.
So kyphoplasty, for example.
Yes. Okay.
I always try to talk I do a lot of kyphoplasty. I think it's a great procedure. But sometimes when I see the patients in the hospital, I'll play devil's advocate and talk about just conservative therapy. And then I let them guide me to say, no, I want the intervention. And so that would be an example of somebody I would consult on, because conservative therapy in the setting of a compression fracture is a viable option.
It was my understanding that inpatient consult codes were a little bit more difficult to get reimbursed for. Like, I didn't think Medicare actually reimbursed for this consult code. I thought like it was a situation where you kind of have to know where your payer is, which to me adds another layer of complexity to it, but I'll let you speak to it.
Again, you're absolutely right. Medicare does not want to pay for these. So when I document my stuff, the billers know that if my level 4 inpatient consult gets kicked back, then it just goes back to a 99222.
Okay.
So that's the trick. That's always your fallback if they say no.
Okay, gotcha. And I think that's probably like sophomore level billing and coding, but I felt like we should throw it out there.
It's getting up there.
Yeah, that is right. So Ryan, there were some specific clinical scenarios I wanted to ask you about, and that was, does your billing and coding change depending on where the patient is? Like, I think there's some specific billing and coding options for patients who are in the emergency room and the ICU setting. And not that we have to get into the actual like numbers on that, but we just talk a little bit, like maybe someone who's like starting to want to push their practice into the next level as far as capturing some codes that are a little bit more on the margins, like in those scenarios.
So the ER has its own set of codes. It's 5 different codes, uses all the same data points that we've been talking about. There's no time component. And if I see a patient in the ER, like let's say somebody's G-tube falls out, I'm on call and I don't want to mess with taking them down to the IR lab. So I'll go see that patient in the ER. I'll swap out the tube at bedside, get a radiograph, and then patient goes home. Patient never gets admitted. So in that case, I would have to bill an ER code.
Okay.
And then otherwise, if a patient's in the ER, I evaluate them in the ER and they get admitted to the ICU, then I can bill ICU codes. If they get admitted to the floor, then I'd obviously bill the other codes.
Okay. So there's some specific codes for patients who are in the ER and the care is taking place in the ER. And there's some specific codes for your ICU patients.
Correct.
Okay.
And the ICU patients, the critical care, you'll see in all your intensivist notes, they say X amount of time spent providing critical care time. So if I have a patient, again, I keep circling back to these cholecystostomy tubes or NEF tubes, but it seems like those are always the sick patients. Yeah. Another good example is a stroke patient. So if I have a stroke patient, let's say they got TPA and they're shipped in, I go evaluate them, decide they're not a EVT candidate, but they have to go to the neuro ICU for critical care support because they got TPA. That's a patient where I could bill critical care time. And I just document that in my note. Patient's critically ill. They have a large vessel occlusion, evaluated for EVT candidacy, wanted to see if they could protect their airway from moderate sedation versus general anesthesia, et cetera. And just document that stuff in your notes. And again, I've had no problems when I document correctly getting this stuff through the billers and just getting it approved.
Okay, great. All right. So one of the things I wanted to switch gears and talk about are that these things, it feels like this is always a moving target. There were some changes for 2021. And can you just kind of give us like the 30,000 foot view of like what changed for 2021 in terms of E&M billing and coding?
Yeah. So the 2021 changes, it's about the most excitement that these things have had since 1997.
Okay.
Again, this stuff has been in effect since 1995. 1997 and 1995, I was 9 years old. Since then, we've had no changes whatsoever. So January 1st, 2021, the new changes took place. And I think that we can extrapolate these changes will eventually apply to inpatient work. Right now, the new changes only apply to outpatient work. So outpatient, where you see a new patient for the first time, and then outpatient where you see a follow-up patient.
Okay.
And just to kind of briefly go over what they did. So if you're going to see a new office patient, there used to be 5 codes, 9920, 1 through 5.
Okay.
Level 1, 2, 3, 4, 5. If you look at CMS data, nobody bills a level 1 office note. So they just deleted that code.
Okay.
And then they made it to where the codes are either based on medical decision making or time as the driving factor. And the medical decision making chart got tweaked a little bit. And then the time component got changed a significant amount. Let me grab this chart real quick.
Sure.
So the old coding based on time, again, I think we should talk about this briefly, but I don't typically code based on time. I will code based on time if I end up in some 70-minute meeting with a family about de-escalation of care.
Right. Yeah.
Or I'm just using the time to capture the work I did.
Okay.
So the old coding based on time, you had to spend the entire time face-to-face with the patient. Over half the time had to be devoted to counseling and or coordination of care. And then you had to document the time spent and the nature of counseling and coordination of care. That's the old stuff.
Okay.
The new changes, I think they've done a pretty good job on revamping this to where it's friendly for the physician.
Right. It's more reflective of people's practices now.
So the new coding based on time can include face-to-face time, can also include non-face-to-face time before and after the visit on the date of the encounter. And there are no requirements regarding counseling and or coordination of care. So basically any time spent preparing to see the patient, seeing the patient, or working on the note after can qualify. And it really makes things a whole lot easier. And then I think with these new outpatient time-based billing criteria, it's going to make it to where time-based billing is a lot more feasible for IR physicians out there, because component-based billing is complex, like we've just been talking about.
Sure.
There are a lot of lingo and other things that can be confusing to somebody starting out.
Well, I guess like that was the whole reason I wanted to have you on, is that I feel like on the surface, like this, it feels like billing coding is like you're constantly going to get trapped. And if you don't have the right thing, it's very tough. But one of the things I hope that comes across in this discussion is that a lot of the stuff it's like you're already doing it. You just have to go like, the extra small effort to make sure that your documentation is tight, because it's work that interventionalists, I think we're all doing. Like, I think a lot of us are going to see our patients. We're having these conversations with patients and family. We're spending the time with them. We're doing our assessments. And then I think a lot of our code, I think a lot of our documentation, it's almost all there. And I think like these electronic medical records are making it to where it's like super easy to just capture a couple of extra data points to where, we're hitting all the markers that we can to capture appropriate codes.
One more thing I forgot to mention about the 2021 E&M guidelines.
Sure.
The history and exam are thrown out. So you can do whatever history and exam you feel is medically appropriate for the patient.
Right.
So all this stuff we were talking about before, the physical exam and the history needs to hit all the points based on whatever note you're coding for. With the new 2021 outpatient E&M guidelines, it's either based on medical decision-making or time. So it's going to simplify everything. And one thing I would recommend for at least the young IRs, when I started my practice or joined the practice I'm in now, typically it wasn't standard for us. We would go see some of our patients, but not all of our patients. So my first year rounding on patients, a lot of the physicians were like, your IR, what are you doing on rounds? When I would round in the different ICUs. And then after about 6 months, it sort of got to be where that was expected. And then, 12 months, a lot of the guys that I would see up in the ICU would then call me with problems directly, just because we were constantly seeing each other rounding. And so for me, starting out in the IR practice, it made it to where I was approachable to other providers, and it made us more open for referrals, I think, moving forward to sort of grow the practice.
No, I think it's a positive feedback loop. You get, one of the things that we haven't talked about is like, just doing this work of going up and seeing patients, like just increases your visibility, 1,000-fold. I think like gone are the days are people who just sit back and you just, waiting for a consult to come through or waiting someone to call you with a case. Like, I think it's invaluable, like building like that, bridging relationships and with like the referring docs. So no, I totally agree.
And we have 5 PAs in our practice, or 4 PAs. We're adding a 5th, and we do not have them do E&M work. They just do parathoras, tunnel dialysis catheters, and a few other things. And I think it's better for the IR providers to perform the E&M work themselves, than to have a mid-level, just because it improves your, like we were talking about, improves your visibility, and then it gets you face-to-face time with the patient.
Sure.
So, and it, to sort of circle back on, this is one of the sticking points to why we left our diagnostic group, was we weren't getting clinical time. We wanted to start a clinic. We wanted time for rounds, and the diagnostic group just wasn't in line with what our objectives were. And, we all kind of sat down and said, we've got to figure out how we want to design this practice. And a lot of us get energy from seeing patients, seeing providers on rounds. That's a lot of positive feedback. And then you go hang out with your diagnostic colleagues, and it's just a lot of negativity.
Sure.
And it reminded me of like a dysfunctional high school relationship where you got that crazy girlfriend that's stealing your shirt and then yelling at you all the time. So, I can tell you, after doing 100% IR practice, doing E&M aggressively for 2 years, I can't imagine practicing any other way. I think the SAR talks really big about we need to do clinical medicine, but we don't have the resources for a lot of interventional radiologists to jump in because we are not taught this. Every other specialty, like urology, what my twin brother does, I mean, they go over this stuff all the time.
So so talk about like, how did you get into this, and like, what were some of the resources that you use? Because I know one of the things that SAR has is there's the SAR toolkit, which I'll link to. I've looked over that a couple of times, but like, what did you use? Did you borrow an experience from other people, or did you have any resources that we can link to? So
the toolkit is basically just they kind of carbon copy the stuff the government puts out. So it's so that's the first thing I did. I looked at the toolkit and I was like, well, this isn't very good. And then I call my brother, and he's like, you're gonna have to go to a course. And then I was like, first year of practice, I was like, I don't have any vacation. So emuniversity.com is by far the best resource. It's an online, you have to pay for membership, but that's what I recommend for any of this stuff. If you may be the guy in your group that's going to focus on this aspect of the practice, and that would be the best place to get sort of expert level education. It counts for CME, and it's only a couple $100. So,
okay. And also understand that you have like a handbook that you made for your group.
Yes, I have a handbook that we'll provide copies of. I don't know how we get it out there, but
we'll get it out there, man. We'll get it out there. Don't worry.
All of my stuff is free. You can do whatever you want with it. This is it's a handbook that we just put in the, I don't wear a white coat. I just wear a vest, but it fits in the pocket of your vest.
Okay.
And it's a good resource to kind of reference.
All right. We'll do that. And then also, guys, we'll also link to your YouTube video, which, personally, I got a lot of value from. Clearly, you put a lot of work into it. And so I hope people go and check it out. Was it tough to make?
Yeah, I mean, I'm, as you can tell, probably not the best podcast speaker, but it just took a lot of time. And so E&M work, a lot of times it's like sex, in that you got to do it a couple times and then you figure stuff out. So you just gotta pull the trigger and start doing it. And then once you start doing it, then you'll know what questions to ask. And so my partners will tell you, when we first started doing this, I had multiple PowerPoints and they were horrible because I just had no idea what I was doing.
Sure.
And then after 12 months, I could really boil it down to these are the pertinent points. So I'm also going to try to get a 2021 update video out because, again, I think that in a year or two, this 2021 update is going to apply to all inpatient work. And it's going to really make it to where any IR will be able to bill for this kind of stuff, and document appropriately. So
the last question, although like we could have easily ended on that note, is like if someone is asking for your opinion on a case, like say a surgeon comes down and wants to know if you can drain an abscess, and you haven't seen the patient, it's kind of like a sidewalk consult situation where you're able to look at the pictures, like with the surgeon there, and you don't have a window. How do you handle that situation in terms of like, do you just ask them to put in the consult and you're like, look, put in the consult and I'll work everything on the back end? Or is there something you do with those that either can go or can't go to your IR procedure. Do you know what I mean?
Yeah. So it depends on to be honest with you, my day. Like if I'm getting slammed and I'm booked out till 9 p.m., then I may not go see that patient. If I trust the surgeon, which all the surgeons at my hospital I trust. But most of the time, especially if it's the weekend, like I feel like my consults really get ramped up on the weekends. I'll go see the patient. And then, one simple thing I've done that sort of added to the practice and people love it, the snipping tool. Do you use that on your notes?
No, I'm not familiar with it. Like, so you go ahead.
I blow it up. So
Nice.
I snip, like if I say there's no window, I'll snip the abscess and I will annotate colon abscess and I'll say, see, I can't stick a drain in that. And all my cases, like, it's funny. We do all these crazy cases, like we'll do crazy tips, but nobody cares.
Nope.
I had a patient that had horrible head and neck cancer and I recanalized their upper venous system and put kissing stents down through the SVC. So really not that complex of a procedure, but I put notes on it and people flipped out. Like all the ICU intensivists were like, oh, that's amazing. The nurses were like pumped. And so I realized then you just put pictures up there and people just love it. So
and that's such a pro move there. And I think I will borrow that. Like, so all it is just using the snipping tool and then that's how you import the picture in.
Yeah. So when people
That's
ask,
great.
like on the findings tab, I just put pictures.
That's awesome. Okay. All right. Well, I think that wraps it up. Any final thoughts about E&M, or any final thoughts about billing and coding in general, Ryan?
I think it's going to be a moving target. I think if you're not doing E&M, I think that you're not practicing to the full potential of an interventional radiologist. We know it's the right thing to do to go see our patients. We know it's the right thing to see them in consult, see them in clinic. So I would just say jump in and do it. And for all you guys in a diagnostic group where you're trying to justify an outpatient clinic, my advice is for 6 months, do inpatient E&M coding. There's no overhead associated with it.
Mm-hmm.
You get a new revenue source, then go to your group and say, hey, look how successful we've been on the inpatient side. Now give us some money for an outpatient clinic that we know is going to lose money. And then you may be more successful.
Yeah.
But I'm also one that would say just do 100% IR, but I think I'm in the minority on that one.
I'm not sure about that, but like everyone's practice is, for everyone, it's an individual thing. And certainly I think that there are people who are in relationships where like they work well with their diagnostic colleagues. Not everything's like butting heads, although that's certainly what we hear about more.
And I would say this, that I agree with you, that I think that the moving forward is going to be a combination of everybody's picture, right? People who maybe do 50% IR, some that do 90%, and usually the market dictates that. So
yeah, right.
I'm not trying to hate the diagnostic guys.
No hate towards the diagnostic guys. All right. I think that about covers it. To the audience, thank you guys for listening. We covered a good topic today. If you heard us reference Ryan's video, we're going to link to that YouTube video in our show notes, and we're going to have links to a lot of other things. I don't have it all figured out right now, but we got some smart team members that are going to make sure it's going to be available to you. So check out the show notes and check things out on BackTable.com. If you enjoyed the podcast and want to support the show, here are 2 easy ways. First, take 1 second, press the subscribe button on whatever platform you're listening on. This helps platforms like iTunes or Spotify know that you, our audience, value what we're doing and you're interested in getting our latest content as we're producing it. Second, if you're really getting a lot of value from these podcasts, please go to iTunes and leave us a short written review. This helps us in a lot of different ways. Plus, we love the feedback. That wraps things up. We'll see you next time on the BackTable podcast. Thank you, Ryan.
Thank you.